عمر هيكلمنا عن indication of cardiac resynchronization implantable cardioverter defibrillator therapy. اتفضل يا دكتور عمر.
ميرفت، شكرا دكتوره مدى، محاضره جميله. احنا محاضره indications of CRT and ICD therapy. دي الالمنتس بتاعتنا. احنا CRT indications هنقسمها ل indications in heart failure management و indications in bradycardia pacing. طبعا ده الالجوريثم الشهير بتاع الثيرابي بتاع الهارت فيلير. symptomatic patients في heart failure reduce ejection fraction HFrEF inhibitor beta blockers، وبعد كده symptomatic MRA mineralocorticoid receptor antagonist، وبعد كده لو symptomatic عندنا اللي هو انترستو والارني، وهنا يجي دور CRT في sinus rhythm QoS duration 130 او اكثر ملي سكند. فهو ده الرول بتاع الCRT في الهارت فيلير الجوريزم. وهنا الديفيبريليشن او الاي سي دي لو الايجكشن فراكشن اقل من 35% زي الاي سي دي برضه despite optimal medical therapy for 3 months. ماشي. or history of symptomatic VTVF. history of symptomatic VTVF ده اللي هو السكندري بريفنشن هنقوله بعدين في اخر المحاضره. فدي ده الانديكيشن، ده المكان الاي سي دي وده مكان السي ار تي والسي ار تي دي برضه، لان هم في اوفرلاب كبير قوي ما بين الانديكيشنز بتاعتهم او الشروط بتاعتهم. ده اي اس سي جايد لاينز 2016 اللي كانت حصل فيها ابديت للسي ار تي انديكيشنز. وهنا كاتبين اللي هو recommended for symptomatic patients with heart failure symptomatic من NIA class 2 NIA class 3 وambulatory class 4 in sinus rhythm QRS duration 150 او اكثر ملي seconds left bundle branch block morphology ejection fraction اقل من 35 او اقل despite optical medical therapy for 3 months to improve symptoms and reduce morbidity and mortality. ومش بس بيقلل السيمتومز، ده هو كمان بيقلل الموربيديتي والمورتاليتي. الكلام ده كلاس 1 ايفيدنس A، واحنا هنتكلم على جزء من الاي اللي قالوا الايفيدنس A. احنا هنا طبعا الاوبتيمال ثيرابي 3 شهور، وبعد كده بنعيد تاني الايكو عشان نشوف الانجكشن فراكشن هل اتحسن ولا لا، عشان نستابلش انديكيشن بتاع الديفايس ثيرابي في هارت فيلير. بعد كده لو هي نون ليفت باندل برانش بلوك مورفولوجي ساعتها هتبقى كلاس 2A بنفس الشروط. هتبقى كلاس 2A لو هي من 130 ل 149 برضه بنفس الشروط هتبقى ليفت باندل، هتبقى كلاس 1. لو 130 ل 149 نون ليفت باندل هتبقى كلاس 2B. الرقم قبل كده كان 120 في الجايد لاينز القديمه 2013، بس الرقم زاد ل 130. بقيت ده في هارت فيلير. في لو ال CRT rather than RV pacing recommended for heart failure patients with ejection fraction regardless of NIA class لو في indication ventricular pacing يعني for bradycardia pacing، وده ملوش علاقه بالنيا كلاس وملوش يعني هيبقى indicated once ان في indication للبراديكارديا وفي reduced ejection fraction. بعد كده هنا برضو CRT should be considered في لو left ejection fraction 35 او اقل class 3 ambulatory class 4 despite optimal medical therapy. ولو البيشنت في atrial fibrillation to ensure biventricular capture is present. ولو biventricular capture مش can be achieved والrate heart rate can be controlled by medications، ساعتها يجي role of AV node ablation CRT. وCRT is contraindicated أقل 130 ملي class 3. الكلينيكال ترايلز هنتكلم عليها early trials ماستيك والميراكل وكير هارت فيلير كومبانيون. The first trial they conducted in Europe, multi-site stimulation in cardiomyopathies or MASTIC study titled Effects of Multi-Site Biventricular Pacing in Patients with Heart Failure and Intraventricular Conduction Delay. وكانت الستادي دي كانت 2001 اعتمدت ان هي to randomize patients into 3 months of pacing and 3 months of non-pacing and crossover between the two groups. So it started two arms, one arm both implanted pacemakers, but one arm is a pacemaker is kept at 40 minutes, that's the backup, and the other arm is pacing. After 3 months, they switch the patients who are active, the pacemaker become backup and the vice versa in the other arm to see the results in both. And the characteristics of the study population, it was around 60 years, weight around 80 in kilograms. Here the heart rate was 75 plus minus, that's controlled on medical treatment. Left the QRS duration was around 170. This was early studies, so it was the conduction delay that signifies dysynchrony. And left bundle branch block in 87% of patients. Left ventricular ejection fraction again 23% plus minus. And this the results. Here's the results or endpoints where symptomatic improvement and quality of life. So symptom improvement was measured in the form of the 6-minute walk test. And in the active pacing group, the patients can walk more than the inactive. So this reflects that symptoms is better than in the pacing group. And this graphs showing the study timeline, which here both arms crossed over, and we noticed that during the active pacing, the 6-minute walk test is better, and the quality of life is better. And here the conclusion was atrioventricular pacing significantly improves exercise tolerance and quality of life in patients with chronic heart failure and atrioventricular conduction delay. Of course, it was then technically complex, and this study looked at the symptoms, but didn't address the mortality. So if you remember when we are reading the guidelines, to reduce symptoms, this is the first benefit we gain from CRT, from these early studies. The second study was the miracle study, titled Cardiac Synchronization in Chronic Heart Failure. And again, this was similar. It was near class 3, around 90% of patients. QRS duration was 160. Ejection fraction again was around 21 plus minus. So again, this study looked at change in 6-minute walking distance and the quality of life. And it proved that compared to medical treatment only, pacing has better effects in this. And the Kaplan-Meier estimates for a time to death or hospitalization for worsening heart failure was better in the CRT group versus the control group. And from this study, they concluded that cardiac resynchronization results in significant clinical improvement in patients with moderate to severe heart failure and intraventricular conduction delay, and this supported the previous study. This study again was conducted in Europe. The effect of cardiac resynchronization on morbidity and mortality in heart failure. This was in 2005. This is a care heart failure study. And as you see, this study is now looking at the morbidity and mortality. So this is looking at the mortality endpoint. Again, they looked at patients with NIHA, included NIHA class 4, ambulatory class 4, with percents of patients, but the majority was NIHA class 3. Again, some patients with dilated cardiomyopathy, not only ischemic. The left ventricular ejection fraction, the median was 25, and the QRS duration here was again 160 milliseconds, and with controlled on medical treatment on guideline advised medical treatment. And these are the survival curves for here. This plot A is the primary endpoint, and this included death from any cause or unplanned hospitalization for a major cardiovascular event. So this is looking at two endpoints combined, and it showed after around 3 years that cardiac resynchronization is better significantly than medical treatment. And this graph depicts only the death from any cause. So this was death from any cause, and this was death from any cause plus unplanned hospitalization. The CRT therapy reduced the hospitalization cardiovascular events and reduced the death from any causes, all-cause mortality. And again, the hemodynamic effects was again reduced. The systolic blood pressure was increased. This was 3 months. This at 18 months. The intraventricular mechanical delay was reduced. The ejection fraction increased, and the BNP improved. And this plot to say the serious side effects then of the procedure related that was in the CRT group, composed of lead displacement, coronary sinus dissection, pocket erosion, pneumothorax, and device-related infection. So this was again caused of this early treatment, and this important complications that we have to bear in mind in order to give patient benefit and avoid these risks. Conclusions were that in patients with heart failure and cardiac dysynchrony, cardiac resynchronization improves symptoms and the quality of life, and reduce complications and the risk of death. The implantation of cardiac resynchronization device should be routinely considered in such patients. This was the conclusions of this study, and this study had two follow-up long-term for this study, the long-term effects of the care heart failure trial. And this again showed that CRT deaths are less than medical therapy only deaths. And again, worsening heart failure and sudden death decreased in the CRT group, and conclude that the benefits of CRT observed in the main trial persist or increased in longer follow-up reduction in mortality was due to fewer deaths, both from worsening heart failure and from sudden death. This reduction in mortality improved the position of the CRT in the guidelines. And again, the long-term, the 8 years follow-up of this trial, clear heart failure trial, published in the European Journal of Heart Failure, again showed that most patients crossed over into the device. For most patients, after the study was completed and established benefit of CRT, most patients of the medical treatment only arm had a device. So if you see here, percent of control group survivors in follow-up with a device increased up to above 90%. And again, long-term follow-up showed that effect of CRT on mortality observed during the main trial persisted. The high rate of CRT device implantation in the control group after completion of the randomized phase of the study may have prevented further divergence of the survival case curves due to a huge amount of crossover. And here, this study is a companion study, was done in the US. So this comparison of medical therapy, pacing and defibrillation in heart failure, a companion study, and this is in 2004. And again, it showed similar baseline characteristics to the previous studies. And here, the primary endpoint was death from or hospitalization from any cause. And here the black arm, is the pacemaker defibrillator. That's the CRT-D. The gray arm is the pacemaker. This is the CRT-P, and this is the pharmacological therapy. And showed that both CRT-D and CRT-P were better than medical treatment, but they were almost the same. And these other curve for second endpoint for hospitalization of cardiovascular cause and hospitalization for heart failure, again, it was better in the PACE group. And it concluded that patients with advanced heart failure and prolonged QRS interval cardiac resynchronization therapy decreased the combined risk of death from any cause or first hospitalization, and when combined with implantable defibrillator, significantly reduced mortality. And this last thing, a meta-analysis was done, individual patient meta-analysis of 5 randomized trials assessing the effects of CRT on morbidity and mortality in patients with symptomatic heart failure. And it included 3,800 patients randomized in 2 groups, and this included other trials, heart failure and other trials, again, follow-up months was up to more than 2 years. It showed the effect of the favorable effect of CRT-P or CRT-D compared to optimal medical therapy. Here is a graph again to showing the QRS duration that where benefit occurs. This is hazard ratio for CRT. Below hazard ratio, this improvement. So this again, this limit for the QRS duration was at about 130 milliseconds. And it indicates that QRS duration is a powerful predictor of the effects of CRT on morbidity and mortality in patients with symptomatic heart failure and left ventricular systolic dysfunction who are in sinus rhythm. QRS morphology did not provide additional information after about clinical response. So QRS duration was powerful compared to QRS morphology, according to this meta-analysis. And from the guidelines, we know that the responders for CRT better with wider QRS left bundle females and non-ischemic cardiomyopathies, and the reverse are less responders. That's why guidelines limit the rules or the conditions for these elements. And we said this before that in heart failure, ejection fraction, and uncontrollable heart rate, we can proceed to immunoablation CRT. And if we can't control the heart failure with medications. Okay. And the upgrade from conventional pacemaker or ICD is indicated in patients with heart failure and high percentage of ventricular pacing, that's class 1. In NEHA class, ambulatory class 4, despite adequate medical therapy, we de novo implantation in heart failure patient reduced ejection fraction that require high percentage of ventricular pacing. For difference between CRT-D and CRT-P, here in primary prevention, the mortality reduction is similar between both, but slightly better in CRT-D. Complications and costs according to studies are higher in the CRT-D, but the CRT-D is favored if the patient have life expectancy for more than 1 year in stable patient near class 2, in ischemic heart disease patients, and a lack of comorbidities. If patient is frail or have other conditions, this points out from the CRT-D. And in arrhythmia, a mode of control of arrhythmia and CRT-D, if we can't control the heart rate like multifocal atrial tachycardia. So here, AV node ablation followed by pacing, preferable biventricular or responder pacing. This again in macroentent atrial arrhythmias, that's ablate and pace. And if we can't control the arrhythmia, and if the patient has cardiomyopathy, cardiac arrhythmia-related cardiomyopathy. In hyperactive cardiomyopathy, cardiac resynchronization therapy to improve symptoms may be considered in patients who come maximum gradient less than 30%. This is important to note to increase the gradient, drug refractory symptoms, and ejection fraction less than 50%, and left bundle branch block morphology. And again, in atrial fibrillation, as we said, we can go for ablate and pace if we can't control the rate. These ICD indications, it's classified into primary prevention and secondary prevention. Secondary prevention is patient who had resuscitated sudden cardiac arrest or hemodynamically unstable VT, and this indicated as ICD class 1. This in all disease if patient have life expectancy more than 1 year and is properly counseled about the benefits of the device and the drawbacks that he may get. Primary prevention, this we judge according to the patient clinical parameters, and sometimes in some diseases there is risk scores that sums up the parameters. So we'll talk about the heart failure first. This is the therapy that precede onset of symptoms. So this is the measures that we take in patients with heart failure that they are asymptomatic or before onset of symptoms to prevent sudden death. And here the ICD indication in patients that are asymptomatic, but with reduced ejection fraction. Here's the cutoff of the LV ejection fraction is 30% or less. And this in the ischemic origin and the non-ischemic origin. And of course, the ischemic origin after at least 40 days from acute myocardial infarction to prevent sudden death and prolonged life. So this is in asymptomatic patients. The cutoff is 30 degrees, 30%. In patients with symptomatic heart failure, the number, as we saw before, is 35%. So these are symptomatic patients, and the conditions are, again, secondary prevention, as we said, and the primary prevention, ICD is recommended to reduce risk of sudden death and all-cause mortality in patients with symptomatic heart failure 2 to 3. Here, there is no class 4. Sometimes it is class 4 if we are waiting transplantation or waiting assist device therapy, but all the studies that support the evidence here are 2 to 3, in contrast to the CRT, which is 2, 3 or ambulatory class 4. Despite 3 or more months of optimal medical therapy. And this is important because sometimes patients improve on optimal medical therapy and ejection fraction increase after 3 months. So it's important to repeat an echo after this period to judge the need for device therapy. And both ischemic and non-ischemic, again, is class 1 indication. And this is in the first period of the myocardial infarction. If sudden cardiac death is feared, we can use wearable ICD. I'll talk a bit about it later. In hypertrophic cardiomyopathy, there is a risk score for primary prevention. I will not talk about secondary prevention because it is the same in all disease. I talk about the primary prevention, and here are the risk variables. We depend on history, the echocardiogram, and the 48-hour Holter. And these are parameters that were associated with mortality. This was a study that conducted this score. It studied the 5-year mortality of patients in this HOCM and found that these parameters are associated with the highest odds of death. So this is family history of sudden cardiac death, age, lung, experience in hope. For this from history, the echo parameters, the left ventricular outflow gradient, the maximum left ventricular wall thickness, the left atrial diameter, and non-sustained ventricular tachycardia in the Holter, the 48-hour Holters, and a risk score was calculated. That's hypertrophic cardiomyopathy risk sudden cardiac death score. And here's a cutoff and 4 and 6. If 6 or more, this is a high risk of 5-year mortality, and ICD should be considered. If between 4 and 6, it may be considered class 2B, and if low risk, less than 4, generally not indicated, but sometimes indicated if here, ICD implantation be considered in individual patient with less than 4% risk, but they have clinical features of proven prognostic importance, and the impact of ICD suggests that net benefit, that the benefit outweigh the risk, and it's contraindicated class C if patients the risk score is less than 4%. And I talk about two studies. That was the first study that showed that there is some benefit from ICD therapy. So this was the first study in 2000. It was called the Canadian Implantable Defibrillator Study. The study randomized a trial of the implantable cardioverter defibrillator against amiodarone. Amiodarone was the gold standard for prevention of these ventricular arrhythmias and sudden death. And here the arrhythmia, the patient characteristics, around 50% of patients had VF for sudden cardiac arrest. So they are all high risk population. And they had again some ischemic, most of them were ischemic, these patients. They beside amiodarone and ICD therapies, they sometimes had other antiarrhythmic therapies. And what they found, amiodarone compared to the ICD, that here the arrhythmic death was less. They didn't differ. This is a Kaplan-Meier curve from death from any cause between amiodarone and ICD, and there was no. The ICD was better, but it didn't reach statistical significance in this early study. But the arrhythmic mortality was better in the for the ICD, and the conclusions were that 20% relative risk reduction occurred in all-cause mortality. So we have two types: the mortality, the all-cause mortality, and the arrhythmic mortality. The arrhythmic mortality was higher, benefit from ICD, and this study showed the early benefit of the defibrillator therapy. And the other study was the CARE study, the cardiac arrest study in Hamburg, done in Germany, and randomized comparison of antiarrhythmic drug therapies, implantable defibrillator in patients resuscitated from cardiac arrest. And this is done in 2000. And here patients were having coronary heart disease, again, the majority. They had the left ventricular ejection fraction around 40%. And all were, most of them were again survivors from sudden cardiac arrest. And here, three groups were compared: defibrillator group, amiodarone group, and metoprolol group. In addition to other therapy for heart failure, and for comparison of ICD for both groups for medical therapy indicates that ICD, there is benefit for ICD. Again, it was better, but didn't reach significance. But for long-term survival of sudden death, this was better between the ICD and the medical treatment group. And they conclude that during a long-term follow-up of cardiac arrest survivors, therapy with an ICD associated with 23% reduction of all-cause mortality when compared to amiodarone metoprolol. And this again was either from the early trial and later trials proved statistical significance in improving in sudden death compared to medical therapy. I'll talk about some entities of ICD, the subcutaneous ICD. It's the subcutaneous lead, retrosternal lead is implanted, and the ICD system is tracked in the lateral chest wall. It has the same effect of delivering therapy, the shocks, but with no bradycardia pacing, so it should be considered alternative to transvenous defibrillator in patients with an indication for ICD when pacing therapy for bradycardia support, CRT or or ATP was not needed. So brady support or CRT or ATP is not needed. Again, it may be alternative. Venous access is difficult, and again, after infections or in younger patients. So these are useful indications for subcutaneous ICD. No venous access, the infections, and young patients requiring ICD. And the wearable cardioverter ICD is important. Is useful as a bridge before transplantation, as a bridge in myocarditis, acute myocarditis, in preparing cardiomyopathy. Sometimes most patients resolve after 6 months, so it's a bridge to improvement or to therapy of the patient. Public access defibrillation. This public access defibrillation must be established at sites where cardiac arrest is relatively common, like schools, sports stadium, large stations, and this again trains and closed like transportation. This is important to decrease sudden death, and these are measures done by the society or by the government. And here معلش بس في كان حد علم بالماركر بس يعني يا ريت يمسحها. Patients with acute coronary syndrome, as we said, during 40 days after myocardial infarction, ICD is not used. Sometimes here in these guidelines, ICD implantation is to be, but if after certain elements in selected patients, like patients with incomplete revascularization can be done, pre-existent left ventricular ejection fraction dysfunction, occurrence of arrhythmias more than 48 hours after the onset of coronary syndrome, polymorphic VT or VF. So these conditions is like some are left to clinical judgment in the contraindicated period of the 40 days after the MR. With a temporary use of the policy. Okay, so in arrhythmogenic right ventricular cardiomyopathy, again, I will not talk about the secondary prevention. This is the primary prevention. It should be considered in patients with patients that hemodynamic well-tolerated VT after balancing the benefits versus risks. So it's if secondary prevention is class 1, if primary prevention is only not primary prevention, the VT is hemodynamically significant. That's class 1. If it's well tolerated, this class 2. And ICD implantation may be considered if one or more recognized risk factors for ventricular arrhythmias were present in this patient, and this is related to the history of syncope, the arrhythmia of non-sustained VT or VT in Holter, and his family history of sudden cardiac death. Again, in infiltrative cardiomyopathies, like amyloidose. ICD is implanted in class 2A light chain amyloidose or hereditary transthyretin associated cardiac amyloidose. This is important cause like in infiltrative disease. They are rare, but this is an indication for ICD. Regarding primary arrhythmia syndromes, I talked about the long QT syndrome, and again, ICD implantation, in addition to beta blockers, should be considered in long QT syndrome patients who experienced syncope or VT while receiving adequate dose of beta blockers. So first we try beta blockers. If patient had syncope or VT during beta blocker therapy, as ICD should be considered. If hemodynamically unstable, it is class 1. Implantation of ICD should be considered in patients in addition to beta blocker therapy in asymptomatic carriers of a pathogenic mutation in potassium channel H2 or potassium channel 5A when corrected QT is more than 500. And this signifies the role of gene therapy. Sometimes there is pathogenic mutations that, if present, it can justify implantation of an ICD. And of course, if genetic therapy is not very common in Egypt, but this is some genes are like malignant, and this is demonstrated in other diseases like Hookham. This similar with this condition. In Brugada syndrome, implantation of ICD should be considered in patients with a spontaneous diagnostic, spontaneous, that's not drug-induced, diagnostic type 1 ECG pattern, and a history of syncope. This both should be present. And because the type 1 is the most malignant type. And again, ICD implantation may be considered in patients with diagnosis of Brugada who develop VF during programmed ventricular stimulation with 2 or 3 extra stimuli at 2 sites. And this, there's an EP study, the VT study in Brugada syndrome, and this is the only disease in the primary arrhythmia syndromes that we can do the EP study. Other primary arrhythmia syndromes, it's contraindicated to do EP study, is not useful. But here in Brugada syndrome, we can do it to risk stratified patients for ICD. Okay. Thank you very much.